Going on, everybody? I'm here with Dr. Emily Kostelnik. What we're going to do today is something that I've wanted to learn more about. So we got Emily here to tell us more, which is learn about the landscape of mental health options for dealing with dizziness. It's something that's super important. It's something that there's a lot of information around, but not a lot of clarity in my experience. So at least for me. So we're going to bring in the expert, Dr. Kostelnik, to help us understand that. So
Awesome.
yeah, excited to get going. Looking
Thanks
forward
for
to it.
having me. Let's get into it.
No one's ever seen Emily's content before. Like I said, she works with people dealing with different vestibular conditions from a mental health perspective. Your training is in mental, talk
Clinical
therapy.
psychology.
Right? Clinical psychology, right? Okay, awesome. So yeah, you've obviously created a ton of very engaging content. You have tens of thousands of followers. I was curious if you could summarize for people who maybe haven't seen your content before, what do you feel like is the message that you've tried to get across? And obviously it's resonated. Why do you think it's been so helpful or impactful for so many people?
Yeah, it's a good question. I think a few things. I think that there are up and coming resources in this space. I think historically there have not been very many resources. And so I think what I tried to bring to the table, or what's unique about me, is the fact that I am someone who lives with multiple vestibular disorder diagnoses, and I'm very open about that. That combined with the message around the importance of nervous system work, of mindset work. And I know we're going to talk about like what that actually means because it's kind of abstract. And I really like to share kind of nuggets of my own experience as I've gotten more into integrative medicine and alternative options. And I think the biggest message I want to get across to people is that you've never tried everything. There are always other things to try. And I'm happy to kind of lead the way on that and share those other things that I've tried with other people, if that makes sense.
Totally. Yeah, it seems like a lot of what you've been doing, especially lately, is helping to facilitate like, hey, can we get people connected with different resources or options, and what works for one person may not for others. Right. So that's kind of why I wanted to talk about the content we're going to go through today, because I agree. It's like, there's a lot of options, not one thing. One thing isn't always going to be the perfect fit for everybody.
Right.
Yeah. Like you said, I think one of the cool things and what I want to get into today is giving people some actual options. I think when you go online, a lot of the content is around like dizzy, anxious, dizzy cycle. Yes, it's a thing. Yes, it's important. But then there's this big gap around like, okay, it's important. So what do I do about it?
Yeah.
Beyond the basics of like, well, you should sleep well and you shouldn't be stressed. And it's like, yeah, all things that we know, but how to actually create those in our lives is something that is not clear always to me, and something that I know a lot of clients have questions about, like, what are the options? That's kind of what one of the next question I had for you is, obviously you have tailored your practice to working with people with vestibular conditions. One thing I hear from clients is often if they find a local practitioner, they have maybe not a great result. They don't feel like the person understands what they're going through. They're not thrilled with the process. If you had to say, like, in a big picture, what's the difference between like a practice tailored towards helping people with vestibular conditions and a more just generalized practice? What would be the big distinctions there?
I think that's the $1 million question, and it's something that I struggle with as well. I think the biggest parallel I can see to chronic dizziness that is more mainstream, that people are being trained in, would be chronic pain. So I think I think that therapists who are experts in chronic pain and have a really good skill set around dealing with that can translate that pretty well to chronic dizziness. The biggest distinction I see between a practice that specializes in chronic dizziness is really understanding the ins and outs of each of the disorders. And another kind of big distinction I see between chronic pain and chronic dizziness is that there are a lot of overlap. So chronic pain feels unpredictable. It might feel out of control. The frustration, functional impairment. The biggest difference I see with chronic dizziness is there is a very deep-seated distrust of your body.
Mhm.
So someone with chronic pain might still be able to drive or be a passenger in a car or engage in the world in certain ways. And someone with chronic dizziness might not be able to do those things. And so I think therein lies the distinction of like that out of control, I don't trust my body level of debilitation. And I don't want to not chronic pain at all, because that can be very debilitating too. But I think it's experienced in a slightly different way.
Yeah, I've never thought about that, but it's interesting. It's almost like chronic pain is a distrust or uneasiness or unhappiness around a certain part of your body that's in pain. We've both been dizzy, and it's like, I almost think for me, the distinction is it creates a distrust in your own like internal processing, like your head, your thought process, your fog reality, which is, like you said, neither is fun, but just unique, different in certain ways. Sure.
Yeah. And I think I don't like to label, or we'll get into the whole labeling and creating stories around things, but in my practice of people who have had classic migraine and vestibular migraine, like consistently will say, I'd much rather have classic migraine symptoms than vestibular migraine symptoms. And so I think that, I mean, both, of course, no one wants either of those things, but I think that kind of highlights just the level of like your entire body feels like it is malfunctioning, rather than, like you said, like maybe it's localized to one part. In certain circumstances, that's not always true, but just in general.
Totally. And like you said, there's a lot of overlap between different things. There's a lot of options. Like every health field, there's a lot of acronyms that are used in psychology, the mental health space, like CBT, ACT, all these sort of different things, DBT. What I wanted to do next is maybe just go back, zoom out a little bit and talk about what are the typical options? What do you find is most used in those situations working with people with chronic pain or dizziness? And then we can get into what you've found most helpful in your practice and some stuff like that. Does that sound like a plan?
Yeah, let's do it.
Yeah. So the thing that I thought was going to be hopefully the best starting point for this section was talking about cognitive behavioral therapy, as it seems like maybe the beginning of a lot of different things that have branched off from there, and maybe the most like classic version of talk therapy. So just if you'd be up for it, outlining like, hey, when is this used? When was it created? Is it helpful for this situation? And then we can get into some other options maybe.
Yeah. So CBT was developed by a psychiatrist in the 1960s who noticed that his patients with depression, anxiety were staying stuck in those states because they had these negative thinking patterns. And from there, kind of this entire therapy was built around that. But it's a lot about being able to acknowledge and recognize when you're having these automatic negative thoughts, as CBT would call it, and intervening on those thoughts. So it's more about changing the way that you think, which can be helpful. I think it's appropriate in certain situations with certain people. If you look at dizziness studies, they're going to say that you need CBT and SSRI and VRT, like if we're talking about triple PD, for example. But there are lots of situations where that doesn't work. And there are people that come to me who have tried all those things and many other things, and they're still not where they want to be. So I think that CBT is by far and away the most researched psychotherapy. So there's over, I think, 80,000 publications on it.
It's kind of like the most established.
Right. So if you go to your neurologist, like that's the type of therapy that they've heard of. So if they're going to refer you to someone, they're going to say, go find a CBT therapist. I think it can be helpful in certain circumstances. So the research would say that it's helpful. The issue I see is that a lot of the people who come to me tend to be very high achieving, type A personality, perfectionist types, and they're very cerebral or very cognitive. They're used to being they're used to being able to try to cognitively problem solve anything in their lives, and that works really well for things other than medical conditions.
And
And so,
I think that's what we want to get into today, because that was my personal experience, and that's the complaint I get from a lot of people I work with as well.
yeah. So CBT is around, again, identifying those thoughts, engaging with them differently. So, for example, if someone came to me and said, I'm having issues with avoidance. I don't want to go on a walk outside because I'm afraid that I'm going to be dizzy. We would look at maybe what the evidence is for that. It would be looking at things like catastrophizing, or are you fortune telling what's going to happen? Or is there all or nothing thinking around that? The issue I see with CBT and dizziness is a lot of times when people are having anxiety or kind of this nervous system activation around doing things, there is a kernel of truth, or they have experienced before. Last time I went walking, I was dizzy.
Yeah.
So I find the issue with it, and I want to say I do use pieces of it in my practice. I'm not a CBT purist at all. The issue with it is sometimes it can be invalidating to the patient if you say, well, what's the evidence for the fact that you're going to be dizzy when you go walking? Well, last time when I went walking, I was dizzy. And so it can kind of feel like you're going around in circles sometimes.
Yeah.
So that is kind of my criticism of CBT in this population. I think in other populations, it can land much better.
Yeah.
So that's kind of it in a nutshell. Does that make sense, or is that still too abstract?
I think that's perfect. And I think most people are familiar with that version of therapy. I feel like if you've ever like looked at mental health, like self-help, a lot of it is around like identifying faulty thought patterns and trying to like rewire that. And like you said, I think if you have an irrational fear, often that makes sense. I think my experience was like, this is a rational fear. I feel terrible when I'm driving, like it's scary and I can't drive safely. Like that's a problem. And like I said, maybe some limitations there, it sounds like. There's some branch offs from CBT from what I understand, which I feel like is natural with, if anybody creates anything, there's going to be a follow-up of people trying to make it better or tweak it for different populations. Well, from my understanding, there's certain things like acceptance and commitment therapy, so ACT, or different kinds of like cognitive behavioral therapy offshoots. Is there any there that you feel like are worth highlighting? Is there any like distinctions worth mentioning, things you find more helpful in that family that would be helpful for people to understand?
So the most common, ACT, acceptance and commitment therapy, is a third wave behavioral therapy. So CBT is a second wave behavior therapy. ACT is a third wave. First wave would be like operant conditioning. So like giving a reinforcement to make a behavior more likely to happen, or a punishment to make behavior less likely to happen. So we're in the third wave now, which is ACT. Another common one is dialectical behavior therapy, which is not as much used in the chronic health space, maybe some pieces of it. The biggest difference, CBT is trying to change your thoughts. ACT is trying to change your relationship with your thoughts. So ACT is a much more mindfulness-based approach. So rather than the push-pull tug of war of like, is this negative thinking? How can I think about this differently? Trying to change those patterns. It's taking the tug of war out of it and more just noticing the patterns and allowing them to be there. So
kind of that idea of you don't have to believe all your thoughts. You can observe them and let them be. So
it's more about being the observer. It's more about not all of my thoughts are true, which using that approach can have a big impact on your nervous system. Like you don't have to go into that fight or flight or of believing everything that you think to be true. It still is a cognitive therapy though. So, and I know we're going to get to kind of the more somatic approach. So CBT and ACT are both considered like top-down therapy. So kind of more from a cognitive approach. The main focus of ACT is to create psychological flexibility. So it's around not avoiding things. It's around looking at what are your values and how do you live in service of those values. Like how can you take behavioral steps to do the things that are important to you, to kind of put the symptoms or the things that we're not trying to avoid, because we don't want to do, like avoidance is not the goal, but how do I put those on the back burner and live the life that I want? And a lot of times the kind of outcome of that is that the symptoms do get better, but that's not actually the goal, if that makes sense.
It's like surrendering to like, I'm not going to try to control this mentally. I'm going to like
Exactly.
do the things and which like you said, it's still under that family of top down, but is maybe a slight step in the direction of where we're going with some of the next somatic type stuff.
Yeah. So and people think acceptance, and that word can be really triggering for them. People think acceptance means I have to accept that I'm going to live like this forever. And it's not what it means. It means I only have to accept what's happening in this present moment. And I'm still going to take steps to improve my situation and trial different medications or lifestyle changes or neuromodulation devices or whatever it is. So it's more about accepting the present moment mindfully rather than thinking I'm doomed or I'm a prisoner of this for my entire life.
Totally. One thing we were talking about in one of the group calls that I do lately is the word surrender, which I think like acceptance has like a negative connotation to people. But what I was recommending, and just from off my personal experiences, just surrendering from the idea that you're going to be able to think your way out of it. And maybe a more like an ACT vibe of like sitting alone in a room and trying to Google stuff is probably not the path forward at a certain point. And does that kind of sound
totally.
like
So a lot of what ACT talks about is living in service of your values. But what that comes down to from a neuroplasticity perspective is you want to teach your brain and put your mental energy on the things that are good and the things that you want and the things you want to engage with. Because if you're sitting on Google all day or you're in the Facebook support groups that make you even more anxious, you're continuing to tell your brain, this is really important and I need to emphasize this. And this is like at the forefront of everything. So if we can kind of try to take those neural networks and make them atrophy a little bit more and build neural networks around balance and community and relationships, or the things that are most important to us in our lives, we upregulate those things and downregulate the dizziness, if that makes sense.
Totally. Time on task of the things that you know you want in your life and are like a normal thing for you. Yeah. And like you said, I think both of these are versions of like top-down therapy. And my understanding of that was based on your description is like we're using thoughts to engage stuff, to try to work through stuff, either by recognizing them and trying to change them or recognizing them and letting them be, but very much around like our thought processes. Is that kind of a safe summary of that family?
It is. So the ACT, kind of one of the biggest takeaways from ACT is that there's a difference between pain and suffering. So pain is the normal part of the human experience. It's what everyone's going to experience in some way or another. So our flavor of that might be dizziness. Suffering is all the extra language and narrative and story and assumptions and expectations that we put on top of that. So ACT says that all human suffering stems from language.
Yeah. Which is, like you said, kind of like very closely knitted to maybe the concept of mindfulness and things like that. The difference between reality and our conception of it, or the way we create suffering with our thoughts, right? It's interesting. I think that's a super, from like, I was trying to prepare for this and like research stuff, but having somebody just explain it in a simple way is super helpful. The next thing that I wanted to get to, and it's something that you've been posting a lot about on social media and some stuff that I've been seeing talked about more, is maybe the other approach or a different approach, instead of like a top-down approach, a more bottom-up approach, where I think you used the term, and we were talking before the call, a somatic approach. I don't know if that's an appropriate term, but go ahead and if you're up for it, maybe contrast that to the kind of top down. So now we're talking about bottom up. Like, what would that be? What would that look like? So
bottom up is more about being present in your body. I know that sounds abstract. And I want to say that I use both top down and bottom up. I think both of them are important. I think a lot of times though, if you're just doing CBT or just doing ACT, you're missing the body component. So when I say body component, a lot of people, especially those high achieving perfectionists used to being able to cognitively problem solve their way out of things, it's almost like that their brain and their body are two different entities. And I know that doesn't make sense, and that's not actually what's happening, but being in your body means being able to be still and putting your attention on your body and not having a panic response to that, which is extraordinarily common. It's very common, especially for people with a history of trauma, which is most people that I work with. I mean, I have seen such severe trauma histories that people can't sit with their body, like with attention on their body for even 1 second. It's very common with neurodivergence, so ADHD, autism spectrum. But anyway, it might include things like somatic. There's a therapy called somatic experiencing, which is all about how do you be in your body without having that kind of neural network of sensation equals panic, and it becomes kind of one neural network, if that makes sense. So one kind of, I guess, metaphor that I like to use is a lot of people approach their body like they would a monster in a closet. So like a little kid's like, I need a nightlight. I don't want to look in my closet. It's really scary, i.e. I don't want to put my attention on my body. Those symptoms are really scary. I need to run away from them. But if we can just open the closet door and see like, oh, it wasn't a monster. It was like just a little mouse. That can be really helpful in becoming comfortable being with those sensations. So it's all about uncoupling the fear with the bodily sensation, if that makes sense. And what that might look like might be something called somatic tracking, which is like sitting and putting your attention on various bodily sensations and just describing them. So describing them like it's data collection. So you're not saying, I feel terrible, I can't do this, I'm feeling uncomfortable. It would literally be, I feel like I'm being pulled to the right, or I feel a tapping sensation, or I have a pulling sensation in my knee, or my knee feels red, or it feels like the texture of gravel. Or so it's using more neutral language to just observe things in the body to try to remove the nervous system, like that fight or flight that you get when you put attention on bodily sensations, if that makes sense.
Yeah. Which for me is always kind of the example that I've had in my own life is more of like around body scan type stuff. That idea of like direct experience without this follow-up of like judgment around that sensation almost. And I know that's like maybe a more kind of Buddhist approach, but like that similar kind of vibe.
No, that totally fits. And there are more like somatic tracking is kind of like, I would say, a gateway type thing, but there are other things that are somatic in nature too. So one of them might be like somatic orienting. So for example, a lot of times when we get super in our heads and we're kind of ruminating and going through the motions with the thoughts, we have tunnel vision, we're on autopilot. So a somatic orienting might be intentionally noticing things around our environment and describing them. Or there's something called like trauma release exercise, which is like putting your body in certain situations and causing your muscles to tremble. So that helps kind of diffuse energy, or shaking out energy. So a lot of times, like if people feel like they can't relax, there are certain kind of shaking out or tapping or various exercises that you can do to try to diffuse the energy. So the whole kind of concept behind it is that trauma is stored in the body, not necessarily in the brain, or not necessarily in the thoughts, I'll put it that way. And so by just doing cognitive exercises, you're missing the opportunity to diffuse the trauma within the body, if that makes sense.
Yeah. And I think it gets back to the kind of broad label of bottom-up approach in which you're attempting to help yourself by engaging with something physical in the sense of like direct physical movement or sensation or something, with the end goal being the same. Obviously you feel better, but like that's almost helping your brain feel better by doing something in your physical body or recognizing something in the physical world.
So this might be helpful for people too. So with trauma being stored in the body, this phrase, what you resist persists fits with the whole kind of trauma storage in the body. So the whole goal with somatic stuff is you want to let bodily sensations and emotions move through you, because typically like an emotion, for example, should peak around 90 seconds and then kind of trail off. So you want to allow sensations and emotions to move through you. You want to interrupt thoughts. So you don't want the story, the narrative, all the language, the assumptions. You don't want to get caught up in that, but you want to be able to let the sensations move through your body so they don't get stuck, because the stuckness is what contributes to like that nervous system activation or that hypervigilance.
And stuck almost meaning like you're running this cognitive pattern in response to this sensation that's like, I'm obsessively thinking or interpreting this in the same way, and it's like always on my mind kind of deal.
And it's usually what people are trying to do with bodily sensations and all of the thoughts that go with it is avoid. Yeah.
It's an unpleasant thing in a way, and you're either trying avoidance or trying to solve it or trying to like correct it. And I think for anyone watching this who's been through it,
I was going to say just get control over it. So avoid and control it in some manner.
Totally. And both of us have had the chance. I've talked to probably 1,000 people going through this. And if I had to say like a summary of the most common mental experience, I think it's that. It's like, I'm having trouble not obsessing over it. It's the first thing I think about when I wake up. I know it was for me. I think about it all day. There's a mixture of fear, concern, trying to figure it out, worried about the future, worried about what it means. And it's like very, very, very difficult to like step away from wanting to concern yourself with it in my personal experience and watching other people go through it.
For sure. And I think that we get stuck in like trying to control it cognitively on some level gives us a dopamine hit. Like we think we're getting control over it by worrying about it. So we're more likely to keep doing it over and over and over. So we're like stuck in this dopamine loop when really it's not fruitful, and we're using so much cognitive energy on that. And so people are totally exhausted and keep going back to the same thought loop, even though we like rationally, we know it doesn't make sense.
And do you feel like that's kind of why often CBT for this population can be tricky? Because it's like we're almost giving people incentive to like think about it more. Exactly. Even if they're trying to correct it, it's like you're almost playing with fire by like, hey, think about it even more. And I know I've had that feedback from people when they've gone and had that sort of help.
Yes. I think from a neuroplasticity perspective, it keeps the attention on the sensations, which is what we don't want to do. Yeah.
It's interesting. Any other stuff that you wanted to kind of mention? I know those were the big things that I wanted to kind of touch on with the bottom-up approach, just kind of trying to contrast that. Anything else there that you wanted to mention before we kind of move on?
The only other thing I can think of that maybe people have heard, it seems kind of up and coming, or it's kind of, I guess, all the rage right now is something called internal family systems, or IFS, or parts work.
Oh, cool. I've never heard of it.
So I would say it probably falls more under the cognitive piece of things, but it's more about realizing that we have different parts of ourselves. Like we might have a protector or an inner critic or an inner judge or the perfectionist, and realizing that we can have these parts of ourselves that are just actually memory structures or like neural networks that are activated. And it doesn't define who we are. Like I am not my protector part. And so if I can create a little bit of space from that, the same way we want to create space from our thoughts, like with ACT, that can be very helpful. That is its whole own like interview, but just a little taste for people if they're interested in learning about other things.
It's maybe that idea, kind of like the ACT stuff of like, we can acknowledge that there's roles we play. Another way to say it in like a Eastern philosophy way would be like, you still chop the wood and carry the water, but it doesn't mean you're a lumberjack. Like you're something separate from this conception of a role. Is that kind of is that what the different stuff would be? Okay. It's interesting. I never heard of that. It's sounds interesting though. There's a lot of different options. That's the thing. That's why I'm glad we're talking about it. And That was kind of my last question in conclusion. Like, I know you mentioned this along the way, but it's a kind of a twofold wrap up. What mix of things do you find yourself using? And is it safe to say that you do find like a little bit of different stuff helpful? And then the second thing would be for anybody watching, how would you recommend they find somebody that could help them with this? Obviously you, if they're in the area or if they're in the states you work in, but
Mhm.
just, I know there's a lot of people that probably aren't or in different countries, and like, how would they go about finding somebody who could offer them what you offer people?
Yeah. So I would describe myself as eclectic. So I use, and I have changed over time. Like
Yeah.
I'm learning in real time as things go on, and I try to incorporate new things all the time. So I would say at this point in my practice, it's largely a combination of ACT and somatic experiencing. As far as how to find someone, again, you could try to find someone who specializes in chronic pain. I
Yeah.
know that you don't want to go and have to explain your life story and explain what vestibular migraine and triple PD are. So you could look like on vestibular.org, for example. They have different practitioners. There are other people that exist that have these diagnoses that are mental health providers. I know they're hard to find. If you want to find an ACT provider, there is a site called contextualsciences.org. You can look
And
on
I'll make sure we link all this in the YouTube description too. So
yeah.
I'll have Dr. Kostelnik send me those links and we'll get them linked. So
Psychology Today, you can filter based on type of therapy, specialization. So you could put chronic pain or chronic illness. If you're trying to use insurance, this is just for the US. I'm trying to think of those are kind of like the top of my head. I wish I had a better database.
well, that's part of it, is like, it's hard to find a database, and you even offering any suggestions is a lot more than people often have. It's usually zero idea of where to turn to because it's not easy. So hey, it's a starting point. And if you're up for it too, like taking a second talking about your work, obviously we can link your website. Would love to give people a chance to understand what you do and how you work with people, things like that.
Yeah. So I'm most active on Instagram at Dr. Emily Kostelnik. My private practice is the vestibularpsychologist.com. So that is to states where I'm authorized to provide telehealth. And I have an education company called rootedbehavioraleducation.com where I have courses, and I also oversee mindset coaches. So they're not therapists, but they're coaches who also live with dizziness and have studied Eastern philosophy and mindfulness and use kind of a similar approach to me.
Yeah.
So yeah, that's where to find me.
Awesome. And like I said, we'll link all that. So we'll get that all set up so you don't have to remember all of those things in one go. So well, I really appreciate it. I mean, I think in a way this was a selfish experience of like, I really wanted to know more, but I'm hoping, and like I said, when we talked, I think my experience has been, if I'm curious about something, there's going to be other people who are curious about it. So hopefully that holds true. And if you're watching this, you found it helpful. We'll give you all those links. And yeah, anything that you wanted to end with before?
I think that's it. Just for everyone to remember that you have not tried everything. There are always more things to try. And I'm happy to help as best as I can.
Totally. That's what I would always try to end with too, is this is not easy. It's not an easy thing to go through. There's a lot of people that try to find help and get bad help, or don't find people who are capable of helping them. And that's frustrating, but there's a lot of very kind people who are trying their best to help, and don't give up. Stuff is treatable for sure. So yeah, well, I really appreciate you taking your time to do this. And hopefully we'll be helpful for everybody out there watching this. So
thank you.
All right.